Hello?
Good morning, everyone. Good morning. Since our moderator has not yet arrived, I feel like we are going to continue because time is not on our side. So I think I'll go first. I'm Nicole Ondisa, a young sex worker from Kenya. I am affiliated to an organization known as Kenya Sex Workers Alliance, which is dedicated to amplify the voices of sex workers in Kenya in all their diversities. So I'll be presenting an abstract on harnessing digital media and social networking for HIV prevention, treatment, care, and support among young sex workers in Kenya. Next slide, please. So this study was focus was to investigate the potential of utilizing digital media and social networking in promoting HIV prevention, treatment, care, and support among young sex workers in Kenya. The aim was to leverage these platforms to provide accessible and engaging information, resources, and support among the young sex workers. Next slide. We used different methodology. One, we used qualitative interviews, and the purpose of this was to delve into the personal narrative and to get a better understanding from the young sex workers as to why they prefer using social media to get information. Our focus area was to explore the delicate aspect of the digital media and social networking. The benefit was to allow to get in-depth insights from the young sex workers and uncovering personal stories. We also use surveys. Our purpose to use survey was to collect quantifiable data on broader scale, which will provide statistical insights, which will also help in programming for young sex worker, where we can use the identified platforms in programming in terms of HIV prevention. Next slide. Here we investigated on the platform usage, the different platforms that the young sex workers preferred to use. And as we can see, they preferred using Facebook, WhatsApp, Instagram. We looked at the usage pattern, where we realized that participants showcased a robust presence on the 3 platforms. It will leverage, our implication was to leverage the platforms to offer direct and effective communication on HIV. We also looked at the interest in HIV information. Are the young sex workers interested in getting HIV information in these platforms? Our findings were participants demonstrated a heightened interest in health-related information, particularly concerning HIV prevention, treatment, care, and support, and sexual reproductive health and rights. It also indicated a readiness and willingness among young sex workers in getting those information in the platforms. And the next slide. We looked at preference interactive content. We looked at what content should be put and in what form. Is it videos? Is it infographics? Which type of content do the young sex workers prefer in those platforms? We realized that tailoring the content to the preference could enhance engagement and efficacy. Tailoring the information, the package that is supposed to be like, if it's infographic, it's speaking to the young sex workers. It is what they want to hear. We also identified different benefits. So yeah, the young sex workers spoke to us on terms of the different benefits of using the social media platforms. One was anonymity, where participants valued the use of digital platforms, since they allowed them to access the information discreetly and at their own spaces without hindrance from anyone. Another benefit was convenience. It showed that it highlighted the ease of accessing health-related information, because sometimes we find that for young sex workers to go and get, let's say, HIV services, SRHR services, there are a lot of stigma and discrimination related to, one, you being a young person, two, being you a sex worker. So getting this information in the social media platform is convenient for them, and it's also curbing the issue of stigma and discrimination. Another benefit, it's a platform for connecting with other peers. As we all know, young people are using social media as a platform of connection, as a platform of sharing information, as a platform of forming groups. So we realized participants appreciated the ability to connect with others who share similar experiences, fostering a sense of community. It emphasized the potential of this platform, not just for information delivery, but for creating a supportive community. Next slide. So we had two key findings. One was extensive use of digital media. We found out that young people, most so young sex worker, are using digital media a lot, which will help us to leverage on on giving different information, not only HIV information, but also sexual reproductive health information, mental health information. So that is one of the key findings. Another key finding was preference for digital interaction. Digital media and social networking are not only just utilized, they are preferred channels for information communication and community building among young sex workers. It showed that the digital media, sex workers don't only use it for entertainment, for just interacting, but they also use it as a source of information, as a source of community networking. Another slide. From this study, we had different recommendations. One was to develop tailored, engaging content. This is where we craft tailored content that resonates and identifies the preference of the young sex workers. We tailor-made the content according to young sex workers. We go to the ground and understand what do they want and put the community at first. We let the sex workers inform the different content that are supposed to be put in the digital media. Another recommendation was to utilize identified platforms judicially. This is where we need to put more emphasis on the identified digital platforms like the Facebook, the Instagram, the WhatsApp, the TikToks, to strategically disseminate content. Next slide. Incorporate interactive elements. This is where we need to integrate interactive elements such as videos and infographics, because we know that using the use of video and infographics, it is easy to remember something that was displayed in video as compared to a write-up of something, and that is very interactive, because as we know now, sex workers are young people, and also young sex workers are mostly on TikTok. When you use TikTok, it's only like 5 minutes video and you pass. So the use of videos and infographics will give more impact as compared to the use of write-ups or blogs. Foster peer support group. This is where we establish and nurture peer support groups within the digital platform. The way we have at our drop-in centers, the way we have peer educators, we also could develop a system of having peer support health group, a social network that is specific for HIV information, for SRHR information, for mental health, which will give a very good personalized approach. This is where we recognize the diversity of preference among young sex workers and tailor interventions accordingly. By this, we mean that we also remember the importance of inclusivity. We also remember the importance of remembering that there are young people, there are young sex workers who are LGBTQ, there are young sex workers who are MSM. We also tailor the messaging to include every young key population in the message, in this strategy. Next slide. Yes, thank you.
Good morning, everyone. I'll be taking over from the last presenter, and I'll be presenting on socio-demographic analysis of an online social support tool, one we call Dr. Dave, in HIV self-testing. You can hear me? Okay, can you hear me now? Thank you. I'm hoping that the slides will come up. Socio-demographic analysis, please. Thank you. My name is Offiong Moore, and I represent myself and the incredible names you're seeing on the slides, who had put on very great feats in ensuring that we come up with these findings. I will take us through the issues briefly, and then I'll discuss the lessons we learned, our conclusion, and then our recommendations. In Nigeria, we had identified that there was a need for testing because there were existing testing gaps. And for us to be able to meet or cover these gaps, we had to come up with innovative tools that would be more appealing for users of the HIV self-testing. And I speak here in terms of HIV self-testing, rather. For us, we knew that initially in history, when it comes to programming for HIV, people got scared because testing, of course, was something that people looked at as though they were going to be stigmatized about. But then for us to be able to bridge that gap and make sure that these test kits are appealing for others or for the users to use, then we needed to come up with an innovative tool to ensure that users are able to go through the journey from the moment where they want to take the test to the moment where they are going for their next step after testing. And that's when we came up with the Dr. Dave. Please, can you move next slide, please? Next slide, please. So through the SHIFT project, which is the Strengthening HIV Self-Testing in the Private Sector, we developed the Dr. Dave, which is a WhatsApp chatbot. And we marketed this WhatsApp chatbot in several channels to ensure that people who were in need of carrying out the HIV self-testing had credible support throughout the journey of testing. Can we move to the next slide, please? Next slide, please. Sorry, please go back a bit. Go back, please. Go back to, yeah, thank you. So for us, we developed a WhatsApp chatbot, which we marketed in different channels. We used both traditional channels of marketing and then the new media. For us, the digital channels we used were basically the WhatsApp, Facebook, we use Instagram, we use TikTok and Telegram to make sure that the HIV, the WhatsApp chatbot, which we had called Dr. Dave, was widespread and people were able to use it. And then for our traditional ways of marketing the Dr. Dave chatbot, we use community mobilization and community activation. The chatbot was marketed and piloted for 8 months between October 2022 and May 2023. Please take note that this was a pilot study. We were just trying to see what works and what doesn't work. And at every point in the pilot, we iterated and got new learnings. We worked with pharmacies as well because we worked in the private sector. Our major channels were the pharmacies and the PPMVs. PPMVs would be the patent and proprietary medicine vendors. I don't know how it's called in other countries, but you might call it chemists. But in Nigeria, they are called PPMVs. So we marketed the test, Dr. Dave rather, on in the outlets, the pharmacy outlets and the PPMV outlets. Another thing that we also did was to market it using IC materials. And of course, we had developed some stickers, which we call the packaging stickers, so that for every test kit that were leaving the pharmacy, it had that WhatsApp chatbot number, as well as a national call center for HIV number, so that any user or anybody that interfaces with the test kits would have access to the WhatsApp chatbot as well as the NCCH number. And these were the strategies that we used. We targeted people between the ages of 18 and above, and from our findings, which I'll be presenting in the next slide, you will see what the trends look like. Next slide, please. So from our findings, you can see that on our chatbots, we had 481 persons land on the chatbots. And out of the 481 persons, we had a 1% fallout rate. What it means is that out of the 481 persons, 99% had engaged the chatbot to the end, while just 1% had engaged to a point and then had fallen out of the engagement. And you can also see that we had more girls or more women, or let's say more female gender, interact with the chatbot much more than we had. Can you move next slide, please? So we had like 59% interaction from the female rather than the male. The male, we only had like 39% interaction. And we had to disaggregate in terms of age. We could see that we had more people between the ages of 21 to 25 access the chatbot much more than those that were older than that were 40 years and above. And this shows us that for us to be able to meet a particular target, then we needed to focus exactly on the young persons using digital innovations. The graph at the right also tells us how the trend looks like. You could also see that between the ages of 16 to 20 up to the age of 36 to 40, we had more interaction, and then we had less interaction from older persons. One thing that stood out for us with the use of the chatbot was that it helped us to identify those who were first-time users. And please go back to the last chart. Yes, so you can see towards the right lower corner that we had first-timers of over 47%. People who had never tested for HIV were able to take the test because we had the chatbot identify them as first timers. And the thing about the chatbot was that the chatbot had different features. You can see from the graph to your corner right that we had different features. It included features like HIV self-testing screening. We had features like find a kit. We had features like risk assessments and self-reporting. You could see that we had more persons who were more interested in testing with the HIV self-testing. And for the HIV self-testing kit, what we did there was to project different types of test kits that were available, and we had videos and infographics telling people on how to use the different test kits. So if you're able to buy an oral quick test kit, then there was a video or a photograph on the chatbot telling you how to use the test kit. And then that applied for the other types of test kits that were available in the market. We could also see that we had people who were interested in finding where to buy kits. And for us, what we did was that we partnered with pharmacies and PPMVs, we did the geographies that we worked with, and we ensured that this PPMVs and pharmacy names were uploaded on the chatbot. So each time people engaged and access the chatbot, we didn't need to find where to buy test kits. The location and exact place to buy test kits were available for them to access. And then one thing we also found out was that self-reporting was quite low. Although people were able to take the test, but they were not confident, of course, to self-report. And this would be something we need to work harder on to help encourage people to upload their results so that we can actually guide them through the next step. And the next step would be, of course, confirmatory tests for those who are reactive, and then preventive services for those who are non-reactive. Also, to also state that on the chatbot feature, we had options and support for those who would want to take PrEP and PEP services. And we realized that we had people who were interested in taking the PrEP and PEP services as well as the HIV self-testing. So we would want to consider our chatbot as a combination preventive therapy for those who would want to access HIV care. Next slide, please. So in conclusion, we want to say that the WhatsApp chatbot was very effective in reaching young people particularly, and provide support throughout the journey, throughout their testing journey. And another thing will tell us that the chatbot holds promise for closing the testing gap, because we're able to find 49% of people who had never tested, and that is a huge number for us, because in Nigeria, we have that gap. We have people who would not go to the conventional testing facilities to get tested. And this was really applaudable to know that there were people who had never tested and were able to get the services and support using the chatbot. And also, we want to conclude by saying that it is highly significant for digital programming. We want to urge those who would want to program for young people to take advantage of the chatbot. It might not be exactly WhatsApp, but you might want to explore that chatbot and see how you can reach young persons who would particularly not go to the facility to get tested. For our recommendation, next slide, please. We recommend that this is an opportunity for scale up. Like I said earlier, this study was a pilot. We're just trying to see what works and what doesn't work. And then we've come up with the conclusion that the WhatsApp chatbot works and will be very good for us to scale up. And not just scale up in terms of where I work, but in terms of those who are programming for young persons in HIV. And of course, there is a need for policy change. We want to urge policymakers to ensure that they include digital innovations in their response to HIV and HIV policy landscape. And then we also want to promote HIV self-testing in the private sector because we understood that we were being very careful not to make the mistake we made in history where we made people feel the need to have some sort of interpersonal communication before they can use a test kit. The HIV self-testing offers people's convenience and confidentiality, and we are saying that we recommend that HIV self-testing should be made available in the private sector so people can actually access the test kit in terms of convenience and anonymity. And I would like to thank Society for Family Health for the opportunity to be here. Of course, I'd like to thank Population Service Initiative for giving the platform. Thank you very much.
Hello? Hello, am I audible? Sure. Thanks, colleagues. I'm known to have a soft voice, so I'll try and project. Can I please have the slides? So my name is Motlatsi Lepono, and I will be presenting on the use of ArcGIS to map at-risk populations in KwaZulu-Natal's male population. My name is Motlatsi Lepono once again, and I'm from Japaigo, South Africa, and these are the co-authors of this particular abstract that we're presenting. So just to give context, next slide, please. So to give context, South Africa remains the epicenter in terms of the global HIV pandemic, with nearly 8 million people living with HIV. KwaZulu-Natal province in particular is known as the epicenter of the epicenter, having the largest HIV prevalence in South Africa. KwaZulu-Natal also has the highest population of uncircumcised males, which predisposes them to HIV infection. Using geographic information systems, GIS, such as ArcGIS, we can actually provide targeted interventions by mapping populations of men in areas and suburbs with unmet needs for voluntary male medical circumcision. Next slide, please. In terms of the methodology that we used, using Stats South Africa data of census of 2011, data that has been extrapolated to reflect the latest populations, and that is by use of the latest community surveys, results for each of the sub-districts, using open source geospatial technologies and data to actually identify and map hotspots on ArcGIS where men can be accessed and reached, and providing this to community mobilizers and district clinical teams. We also used mapping of health facilities throughout the province to understand the proximity of clients and study the relationships of the distance between them and also the facilities. We also used aerial GIS imagery to identify high residential areas, such as informal settlements. ArcGIS spatial analysis of our own VMMC database of clients that contains geographical and demographic information, such as well as HIV status against the census data with economic indicators and open source data. We also used information provided by our community teams to mobilize in areas with unmet needs and also to follow up with partners for HIV testing and treatment. We also understand that there is no one-size-fits-all approach, especially to GIS analysis. Using different information will also provide different results or outcomes. Hence, we require an integrated approach of the use of data to identify vulnerable communities with unmet needs. Next slide, please. In terms of mapping examples, we used bivariate analysis on ArcGIS that was selected to visualize information about men that were circumcised and the population, as it is easier to interpret those results at the scale. We also performed proportional density and dot density to interpret the information on a smaller scale. Bivariate analysis of the number of men that were circumcised at a certain suburb and also the sub-district level. Bivariate analysis of the number of circumcised males against the population, and also looking at the health facility location and the type of that location, and also bivariate analysis of the number of HIV positive males and the number of circumcised males at a main suburb as well as a sub-district level. Next slide, please. Now, on this map that we're looking at, the bivariate analysis of the circumcised men against the male population at a main place or suburb level. And this particularly shows that in areas where we have that orange color, we have a high number of males and in that orangish color, which is what you're seeing in the northern areas of KwaZulu-Natal, in Zululand district, in particular, King Cetshwayo, and some areas of eThekwini, we are seeing areas where there's a high population of circumcised males, as well as a high population of males in particular. And in areas where we are seeing the more darker red color is where we can actually see that there's also a high, a high population of circumcised males, and also a low population in terms of males in particular. So we were able to look at this data and be able to see what else can this data be able to tell us. Next slide, please. In terms of this, we looked at the population of males at a sub-district level. And what we could see is that, in particular, we are looking at those particular districts. We could actually map out sub-districts where we can see that there are males who may not be having essential services or enough services. For example, if you're looking at Alfred Duma, which is in the Utugela district, which is on your left eastern northern area, you can see that there are males where we have a high number of circumcised males, as well as a high number of population of males in particular. But in areas such as King Cetshwayo district, we can see that there is also a low number of males and also a low number of people that are actually getting circumcised. And that's where you're seeing areas such as Nkandla, Mthonjaneni, and Umfolozi. Next slide, please. And also here in this map, we also mapped out the population of males that were getting circumcised or that were getting services. And also we looked at where are they fixed health facilities that offer male medical circumcisions. And those are the blue dots. And also where we are seeing where there's also outreach services, which means that men don't get services on a regular basis. It is on a scheduled basis. And that's where we are seeing the pink dots. And this is where we try to correlate the data to say, in areas where there is a high population of males, are there enough facilities that offer services on a regular basis versus areas where there's a low concentration of fixed sites or areas where males can get VMMC services on a regular basis? Next slide, please. We also looked at the data, given that we wanted to also see where are the HIV positive males versus the population. And we were able to see that within this map, if you look at the more northern areas towards the Eswatini border, we could see there's a high population of HIV positive males versus a lower population in terms of circumcised males. And in areas such as Vryheid, which is in Zululand, we're looking at areas such as Alfred Duma within the Utugela district up there. We could see that there is a low number of males that are getting circumcised, and in general, a lower population of males that are available. And in this data, we're looking at basically the same at a sub-district level. And these are just and next slide, please, sorry. And here are just the results basically of the data that we have collected in terms of Japago's VMMC data. Next slide, please. Thanks. And this is just the data that we were analyzing in terms of Japago's VMMC data between 2020 and 2023, looking at the number of males that have been circumcised that were HIV positive versus the total population of males that were available in that area, in a particular area, and also looking at the percentage of circumcised males in a particular population versus the prevalence as well. So using this data, we could basically also map out where are we seeing a higher incidence of males that are getting circumcised Are they having enough facilities in their area versus areas where we believe have unmet needs, looking at the data on the map, especially where we see that we also don't have more fixed facilities in those areas. We have more outreach facilities so that we could now change and make sure that we channel our services to address those males. Next slide, please. Here, what we were also looking at is also the proportion of males that were circumcised in a particular area versus the percentage of males in that particular population. And what we can see is that on the first side, we're looking at Umdoni sub-district, which is in the Ugu district, where we are seeing that there is a low, where we are seeing that there is a particularly high number of males that are circumcised versus quite a low population, compared to areas such as the eThekwini district, which is on your far right, where we are seeing that there is also a high number of males that were circumcised, but overall, in terms of the population, we are seeing that it's a lower percentage of the population overall, because eThekwini is a high density area. So not enough males are getting circumcision services in those areas. Next slide, please. Here we're also looking at the prevalence of here we're looking at the circumcision versus the HIV prevalence. And what we could see is that in sub-districts such as Umdoni sub-district, there was a high number of males that were HIV positive that were circumcised versus the prevalence of circumcised males in that particular area. And once again, in eThekwini, we are seeing that there is a high prevalence of males that were getting circumcised, but also quite a high but also quite a high prevalence of men that were actually receiving services. But overall, we could still see that the percentage against the total population was still low. Next slide, please. So what did we do through, what did we learn through this particular study? We were able to identify areas with unmet needs, particularly areas such as Utugela district, Kingsatwai district, and Ugu district. And basically, these are the more rural districts that needed more services. We were also able to identify areas within eThekwini district, which is a more suburb or some more a more rural district, a more urban district. But also within that urban district, we were able to map out and identify areas within that particular district that have unmet needs, such as Amawoti, Tongat, and Verulam, which is in the northern areas of eThekwini, and also the southwest areas of eThekwini, where we identified that although it's a urban district, but there are rural areas, and these are the areas that do not have enough needs. Okay. Colleagues, I see that the screen has just become dark. We were also able to identify that there's a significant majority of areas with unmet needs. And as I mentioned earlier, we will also identify that where there's those unmet needs of male circumcision, we also identify that there aren't enough health facilities available in those areas. And also we were able to identify areas or sites where we have a high number of males that were accessing VMMC services, which is the voluntary male circumcision services, but also we identified the fact that in those areas, we had quite an ample amount of facilities that were offering services to that particular geography. Next slide, please. All right, I'll just talk through while they try and sort out the technology. So in terms of the HIV prevalence, we will also used GIS analysis that showed that there's an increased there are increased HIV positive clients in high density areas with lower income suburbs, such as your informal settlements. We also were able to map out that there's a high number of males that are HIV positive and that were identified in towns and cities compared to rural areas. So we know that there is a high number of people that are moving to urban areas. Within the eThekwini district, we saw that it has the highest population in the province, but also had the highest number of clients who were HIV positive. And within those areas, we also saw that Utugela showed that there is also a high number of males that had a high positivity, but also that is a rural district. We used the bivariate analysis that indicated that within the rural areas, such as Zululand and Kingsatwai, there is a high number of males that were HIV positive compared to their population. And that we could also attribute to the fact that these are areas that were bordering KwaZulu-Natal. So those are high traffic areas. And we know that those areas that are bordering KwaZulu-Natal were also bordering other countries as well. So we could see that those are high traffic areas as well. And the coastal areas such as Ugu and Kingsatwai districts showed a higher numbers of HIV positive patients. And these suburbs were also settlements that showed subsistence farming in those areas, fishing and informal labor, which were the main indicators, which were the main sectors for employment, and further evidence of lower income generating communities, which means that those areas definitely needed more support in terms of services. So how did we then, as JAPIGO, use this information? All right, I'm hoping that they're catching up. So because we were able to identify these areas with all of these unmet needs, we were then able to direct our services to those areas using the information that we were able to get from ArcGIS, where we have identified areas with unmet needs. We also were able to increase awareness and demand generation in those areas where we were not providing adequate services. We were able to obtain consent from clients and provided information on those HIV positive males to other partners and the Department of Health for ART initiation. We were able to also ensure that our community mobilizers were able to visit those particular areas where we saw HIV was prevalent, and also make sure that we are more visible and frequently educate and mobilize those community members to get circumcised and get tested for HIV, and hence reduce the prevalence. And also increasing the number of outreach facilities in areas where there are not any fixed sites. Also, within those sub-districts show that a higher population density and prevalence, and within those sub-districts where our teams were not going more frequently. And we're also able to identify areas where we were not providing adequate services by measuring the number of circumcised clients against the population and against the facility type and frequency of VMMC services that were offered. Thank you. So in terms of the next steps, we wanted to use the spatial temporal analysis of circumcised men versus the population using ArcGIS and census data of 2023 when it becomes available. Over the past 2 years, we know that in South Africa, we had a census that was being done. So we are waiting for that data to actually come out and be able to map also against the same system so that we see where are these areas where we have provided an impact, and basically have we made a difference overall. We also wanted to use spatial temporal analysis of ArcGIS of HIV positive male who have come for circumcision. And this is the analysis of prevalence over time within that particular province of circumcised males. We also wanted to develop and also test machine learning techniques to identify and predict which suburbs will have increased HIV prevalence in future, and also model circumcision and also HIV prevalence in male against the census data to understand how the dynamics and relationships of employment and of employment status affect circumcision and prevalence in those particular areas. I also just want to acknowledge, next slide, please. We also just want to acknowledge PEPFAR through CDC and also the JAPIGO team, both in South Africa and also within the region for the support. Thank you so much.
Thank you. Thank you for listening in. I am your moderator for today. So I appreciate ourselves. Sorry. I'll open the session for questions. We will take only 2 questions because of time. So anyone with a question, can I have a volunteer to pass over the mic kindly? Thank you. This question. Anyone else with a question? 1, 2. That's all. I'll just take 2 because of time. Okay, thank you. Go on.
Thank you very much. My question is to the last presenter. It was a very insightful presentation, but however, I'm a bit concerned. The data that was used is 12 years ago. So I'm not sure if the situation is still the same, given that there is rapid intervention in such issues of late funding towards prevention, and men circumcision has increased. So I think you might need to look into the data, because making decisions basing on the presentation might be misleading, because we're looking at 12 years ago, more than a decade.
Thank you all for the presentations. I had a question. You mentioned how peer support was something that was really needed by the young sex worker community. And we also hear sometimes groups are worried about forming online due to safety. So I'm just wondering about any suggestions you have as far as safeguarding those who join groups from any sort of harassment. Thank you.
Thank you for your questions. I'll let my colleague first answer the question directed to him. Yes.
Sure, thank you so much. So definitely, I think we also had the same concern. So as we were working through this, we actually were in touch with Stats South Africa, who have recently conducted, as I said, the most recent survey, which was in between 2022 and 2023. So in the last 2 years, they have actually conducted. So how best can we use the data, because it is quite old? And they did also give us some ways of being able to actually use approximations, because they've been using community, or rather they've been conducting community surveys. So every 5 years they do conduct community surveys. So they do pilot and they do actually reach out and go into different communities every 5 years. And they're able to sample and see how is the growth in those particular communities. So we were able to engage with them and get more closer data, or rather they gave us an indication of how best to calculate in terms of the data that we were looking at. But definitely we do agree that the data is quite aged, and hence we're also looking forward to the data that is coming out. We should hopefully in the next year, so that we are able to redo this exercise and be able to give more accurate data. So I think that is work in progress. Thank you so much.
Thank you. So I will respond to the question directed to me. So security is a big challenge, more so in terms of the social media. There's no way we can have control of the security in the social media, but we are trying as much as possible to use the social network. Where I am a young sex worker, I know young sex workers who are very active in the social media. So I use the network that I have as a young sex worker to reach to other networks, like using my network to reach to my other peers and young sex workers. The other young sex workers uses the to curb the issue of security, but security is a major challenge, and it's just something that we don't have control over, but I hope with time we will have control. Yes, thank you. And also we are having, like in Kenya, ICASA is having an app that is used to disseminate information. That app is used, like it has peer educators who are disseminating codes for young sex workers to download the app and use the app as a source of information and as a source of just interacting with it. So we know that by using my network, it can reach to another person. So yes, we are trying to use social networking structure. Yes, thank you.
We take up the last question.
The last question only, and then we close the session. Thank you.
Yeah, thanks, Tim, for the presentations. My name is Ronald Kizito from Uganda. Throughout this conference, we have had discussions about sustainability. And when you presented the different learnings around the digital platforms, it got into my mind that across what is in Nigeria, what is in Kenya, what are the sustainable opportunities are you looking at to ensure that these digital platforms are not pulled down when maybe the donor is no longer making money available? Look at a WhatsApp chatbot that has been supporting the targeted population, provide access to information over time, and there are costs associated with it. If a donor pulls out, it goes down. So what opportunities do you see in your country to leverage on to sustain digital platforms? Thank you.
So from our study, our organization, we are trying to integrate integrate to the existing